I invite our next speaker, Kılınçer from Turkey, professor, also very, very famous, very well known. And he will give us a hint on discectomy or anterior foraminotomy for cervical disc herniation. Looking forward to your lecture.
Thank you. Is my screen coming?
Yes.
Yes, perfect.
Hello, everyone. I would like to pass my experience and opinion about the anterior foraminotomy and its relationship with anterior discectomy. How we choose and how we decide about that technique. I would like to start with a case. This is a 39 years old male with right arm pain for 3 weeks. He is neurologically intact. How do you manage that case? Look at the MRIs and think about it. I will show the case solution at the end, but I just want to provoke some idea thinking about how to approach that kind of cases. This is second case. This is a much older female, 60 years old. She has left arm pain for 6 months. And neurologically, she has C6 root involvement, no myelopathy sign, and she has a osteophyte at the left side, symptomatic side, at the C5-6 level, as you can see. So how do you treat it, and what is the difference of that cases? This is my algorithm about how to approach disc herniations. Of course, every case needs a different approach, and we need a lot of weapon in our armamentarium. So we need to select the techniques case by case. I will discuss that slide later. We see the problem of osteophytes in mainly 3 locations: discovertebral location, uncovertebral location, and facet locations. Amongst them, uncovertebral and facet osteophytes cause radiculopathy. So in the practice, in the daily practice, I see that most of the radiculopathy is caused by the osteophytes or foraminal narrowing rather than soft disc herniations. So we need to, sometimes they are combined. There are combined lesions, so we need to think about the osteophytes. We have these are the options to operate that kind of cases. We have anterior approach. We have anterior cervical discectomy, whether it is microscope or endoscope. We have anterior foraminotomy. I will mention about it. We have ACDF and disc prosthesis, and posteriorly we have posterior keyhole foraminotomy performed by microscope or endoscope. Anterior cervical discectomy is a standard approach to for discectomy generally. It's in a sense a minimal invasive approach. There is small skin incision. There's no muscle dissection. Use anatomic planes. But after discectomy, what you need to do? If just remove the disc and the lesion, the disc herniation or osteophyte, there may be some alignment problems. That's why we apply some cages or graft and plates. This cause fusion and may change, disrupt kinematics, cervical kinematics, because you just void one disc level, and there may be some problems after that. And there is an option, prosthesis. This is a promising one, but it has its own problems, but it is not ideal. An ideal operation for cervical spine should completely eliminate the offending pathology, whether it is soft disc or osteophyte, but also should preserve normal motion kinematics. If you make a fusion, you alter the motion kinematics, of course. So in principle, ACDF cannot be an ideal operation. And also the surgery should cause minimal collateral damage. So the question is there a surgical corridor to resect uncovertebral osteophytes without disrupting anatomy? Indeed, yes. You see in the left side there is a lesion here. This is a disc herniation or osteophytes. Generally, we decompress this lesion passing through the inside the disc, and disc itself is innocent. So the disc is not cause problems for the patient, but to reach there, you just sacrifice the disc. On the other hand, we have a corridor to reach there. This is inside the vertebral body. So this is, in essence, the anterior microforaminotomy. This corridor just behind, just underside the longus colli muscle. You see the longus colli muscle in the red, and this is the corridor to reach there. So if you can use that corridor, you don't need to resect disc interspace. Of course, some surgeons, some colleagues offers some other solutions to resect the lesion without disrupting the disc. This is a Turkish colleague of us. He just make a contralateral partial discectomy, remove the disc herniation, and put some fat graft, hoping there will be no fusion. So this is another approach without fusion technique. But our topic is anterior foraminotomy. So this is relatively less known technique. I think a few surgeons use that technique. So I will mention about the technique briefly. You see the intervertebral foramen. This is anatomy. It is bordered anteriorly from the uncinate process, and superiorly, inferiorly pedicles, and posteriorly from the facets. Intervertebral foramen. This is oblique view. You can have the best view from the oblique view. And this is the area of problem generally. Disc herniations, lateral disc herniations, and uncovertebral osteophytes involve that area, and that area just neighborhood at the root. So if you remove that area, you will decompress the root. This is the principle of anterior foraminotomy. So that technique consists of anterior approach to the lateral 1/3 of the vertebral unit, and there will be direct nerve root decompression by excision of the uncovertebral osteophytes or protruded disc material via a foraminotomy at the location of uncinate process, and special care is employed not to disrupt disc. There are some synonym names: anterior foraminotomy, anterior cervical foraminotomy, uncinectomy, uncoforaminotomy, or transorbital cervical approach, all used for the same technique. This is history of what is that techniques, lateral techniques to the uncinate area. In the sense of we understand the technique today, Dr. Cho, Haidong Cho, and a Korean surgeon practicing in United States coined that technique and described the technique in the sense of we use today. And we acquired and learned that technique directly from him. This is Dr. Cho. Best indication for anterior microforaminotomy is uncovertebral osteophytes. You can remove lateral foraminal disc herniations with that technique also. I will show an example, but the posterior foraminotomy is a much preferable technique for that kind of indication. So although you can remove the disc, uncovertebral osteophytes is the best indication for that technique. This is visual to describe the technique. This is the regular anterior exposition. This is drilling area, and after drilling the area, you remove the osteophyte or disc herniation from that hole. There are 5 steps of the surgical technique, and routine anterior cervical opening, opening the 3 fascia to reach the area. You expose the uncovertebral joint, generally by resecting some longus colli muscle at the lateral border of the vertebra here. And you need to choose your drilling area. You can use all of 3 areas to read. This is related with where you put your skin incision, where is the lesion, but you can use all of them to start drilling area. And this is area. If your skin incision is above, you need to drill superior vertebra, or here, or here. All of them are okay. And after drilling, you need to resect the posterior cortex, then osteophyte, and you need to see the root directly. Tips and tricks, of course, there should be precise neurological localization, which road is involved. Preoperative planning with MRI and CT to see the exact site of compression, anatomy of the anterior bony supports and course of the vertebral artery. And selection of the entrance point depends on level and skin incision angle of view. We use 3 millimeters diamond burr generally. And at the end of the surgery, you need to see the root directly. Postoperative no collar use is necessary. Of course, there's approach-specific complications. There is trick to directly visualize structures like vertebral artery and sympathetic chain, but these complications reported very rare. And insufficient decompression, especially at the learning curve, is very possible. We see that in our cases also. And this is the solutions of the case I show you at the beginning of my presentation. This is 39 years old male with right arm pain. There is soft disc herniation. The treatment we choose is just injections. Indeed, I generally don't operate soft disc herniations, and the resolution rate is very high. So I just control the pain and wait if there is no gross neurological deficit, of course. And this is the visual of the view of the cervical transforaminal injection. It is not a difficult technique, and it yields very good results in soft disc herniations. This is second case of I show you. This is C6 root involvement. There is neurology in that patient, and we operate that lady with anterior foraminotomy from that view. And you see the area of bone resection and removal of the offending lesion. And this is that shows the extent of bony removal after that surgery. This is 3D. And this is another case, a soft disc herniation. Today, I will operate that patient with posterior foraminotomy, not anterior discectomy, not anterior foraminotomy, but posterior foraminotomy. But you can use posterior foraminotomy, that kind of lesion also. And you see the bony hole, bony corridor to reach there. And from that corridor, without disrupting the disc, you can remove the disc herniation also. But this surgery is a very meticulous, long, and stressful surgery. So I will prefer to posterior foraminotomy rather than anterior, that kind of indication today. In conclusion, I can say that an ideal operation for cervical spine should completely eliminate the offending pathology, whether it is soft disc or osteophyte. It should preserve the normal motion kinematics, and it should cause minimal collateral damage. An anterior cervical foraminotomy indeed causes minimal collateral damage and eliminates the offending anterior pathology directly without disrupting normal motion kinematics. And this is my algorithm for cervical radiculopathy, whether it is caused by a disc herniation or osteophytes. For lateral soft disc herniations, my first line of treatment is injection of always, and then if patient does not get better, I will apply posterior foraminotomy. For foraminostenosis, I will again try injection, and if patient does not get better, I will again perform a posterior foraminotomy. For lateral disc herniation and uncinate osteoporosis, I will again try injection, then posterior foraminotomy. Although the lesion is anterior, posterior foraminotomy is sufficient in 99% of the cases, and in some very selected cases, anterior foraminotomy could be tried. For large disc herniation with canal stenosis, indeed, these are not cause radiculopathy generally, and with kyphotic posture patients, I will apply ACDF of disc prosthesis. This is my algorithm for the cervical lesions generally. So thank you for your attention.
Thank you, Dr. Kılınçer, for your very comprehensive and didactic presentation. And, you know, just for the young people in the audience, this is a quite technical surgery. It's easy to get lost. I'm also used to do that, but I prefer since the beginning to control the vertebral artery, because the ulcovertebral joint is very, very close to the vertebral artery. At C5-6 level, for example, is 2.6 millimeter, the lateral margin of the joint to the medial edge of the vertebral artery. So there is a question here from Oz Danner. What are the complication rates, this approach for vertebral artery, sympathetic chain, and I would add also the Horner syndrome.
In the literature, the results looks very good. I think the complications are underreported because many surgeons can try to that technique, may start to apply that technique. If there is some complications, they just quit and don't report that. But if you look at the large series, I mean 20 cases, 30 cases, 50 cases in the literature, vertebral artery, which is most dangerous structure at the area, injury is much less, very rare, very, very rare, similar to the other anterior techniques, not more than.
Right.
And the
one has to pay attention to preoperative scan, because you can have 80% of patients with medial loops of vertebral artery, or the vertebral artery can be anterior to the foramen. So, you know, I advise all the participants here, if they want to do this technique, to be very careful and pay from anterior foramen